things that people don't want to talk about, but it happens. Anyway, so we ended up last time talking about infertility in males, and now we're going to talk about sexual intercourse, which is also known as coitus or copulation. So, in order for this process to happen, which is the penetration of the male penis into the vagina in females, so you have to have erection, which is basically the process where you have collection of blood, sustained collection of blood temporarily in the corpora cavernosa. So the blood vessels in the penis during the flaccid state, they are collapsed or constricted. But sexual stimuli will lead to a reflex from parasympathetic nervous system that is going to lead to the release of nitrous oxide. So this one is going to help for these endothelial cells in the blood vessels to basically relax and to allow the dilation of the vessels. So nitric oxide is a vasodilator, and that will allow for the blood to enter into the corpora cavernosa, and as it's entering and filling the spaces, the penis is going to erect, and then that will collapse the veins that returns the blood supply, and then that will maintain the erection. So the penis become engorged with blood. So then that maintenance of this erection happens again because you will have compression of these dorsal veins of the penis, and something that will happen during that process is going to be ejaculation. So in ejaculation, you will have release of these sperm cells from the epididymis, and then you will have a series of contraction of these muscles of the ductus deferens that is going to cause peristalsis of this organ, and then you will have rapid transfer of the sperm cells into the ejaculatory duct, and then with the aid of oxytocin, you will have contraction of the prostate gland, release of the prostatic gland fluids, seminal vesicle fluids, and then in the ejaculatory duct you form the semen, and then you will have the release of these sperm cells into the semen into the urethra, and this will happen because you have nerves of the sympathetic system that controls this process. Now, emission, it will be the movement of the sperm and testicular fluid and semen into the urethra. So that's emission. And then when the semen accumulates in the urethra, that increases sexual tension, and then you will have a reflex from sacral nerves into the spinal cord that is going to lead to the rhythmic contraction of the pelvic muscles and then release of the semen by ejaculation. So parasympathetic system, it is important for erection, sympathetic system for ejaculation. And then orgasm will be the sensation of pleasure, and this will be coinciding with the process of ejaculation in males, and then there is going to be a period of resolution in which the penis will be relaxed, and then the blood is forced out, and then this is going to be a refractory period, latent period after ejaculation that can last from minutes up to hours, and a male is not capable of having another orgasm. Now, for erectile dysfunction, so which is the inability to maintain an erection. So there are several causes and factors, including stress. So stress plays a major role in this erectile dysfunction. And then we have also depression, anxiety, which are psychological causes, all of three of them. And then there are some physical causes, including damage to the sacral nerves by cardiovascular disease, in which the blood vessels will be occluded, or maybe they will be very rigid, the walls. And this happens not only in cardiovascular disease, but also in diabetes mellitus. And in diabetes mellitus, you also additionally can have damage to these sacral nerves, obesity, tobacco, alcohol use, and some prescription medications can cause erectile dysfunction. And then as the males become older, their levels of testosterone decreases, which basically that can be another cause of erectile dysfunction. And as well, there will be reduction of blood supply to many organs, including the penis. And the treatment for erectile dysfunction can include taking some medications that are vasodilators. And when it comes to those ones, there are some medications that can have a potent vasodilation effect, not only in the blood vessels from the penis, but also some other blood vessels from the body. And it is necessary to warn the patient about this because they can become dizzy. And then they can be, if there is some structural damage to the pelvic organs, there can be some surgeries that can help to repair any damaged blood vessels. Or in some cases, some males, they opt for having penile implants. So questions about erectile dysfunction? Okay, now for puberty. Puberty is this period of time between childhood and adulthood in which the testosterone and androgen levels are initially secreted in small amounts, but they start increasing in larger amounts as the male increases its age during puberty. And this happens because you have release of GnRH, which is the gonadotrophin releasing hormone that is released by the hypothalamus. And then before that period, the hypothalamus, it was inhibited to secrete GnRH. But then as time progresses, this tissue, I was going to say organ, but this tissue becomes less sensitive to its inhibition and secretes GnRH, which is going to stimulate the anterior pituitary gland to secrete FSH, LH, which is going to go into the bloodstream and then go into the testicles, where it triggers the production of testosterone and then spermatogenesis. And then the development of secondary sex characteristics that I already mentioned last time. And the time of puberty varies between 12 to 14 years of age. And it is evident in males when they start puberty. And hormone levels usually stabilize a few years after the onset of puberty. So again, what are the secondary sex characteristics? Well, the growth of terminal hair, like pubic hair, axillary, and facial hair in the mustache area, the beard area, along with increased size in the larynx, which make the males to have a deeper voice, also thickening of the vocal cords, and then the thyroid cartilage become enlarged, making appearance in the neck area to look what we commonly known as Adam's apple. And also the skin of males become thickened, the activity of the sebaceous sweat glands increases too, and that sometimes results in acne, and the bones become denser, the muscles become denser as well, and because you have more bone tissue and then more muscle tissue, you require more blood supply. So they have more secretion of erythropoietin, which makes them to have more blood volume and more red blood cells than females. And then that increase in testosterone also leads to increase in the male libido, which libido, it is desire for having sexual intercourse or sexual activity. I don't know if you have heard about this, but it exists, but not so many people know it. So males, just as females, undergo a period of time where you have some decline of physiological functions. Not necessarily has to be sexual function, but basically is the analog of menopause. So this is andropause. In males, usually happens gradually and may begin in the early 50s. So something that happens, just as for females, in which for us we have reduction in the size of our breast tissue, in males will be reduction in the size and weight of the testes, and this can be because there is a decrease of sustentacular interstitial cells, because there is less input from GnRH, FSH, LH, and there might be a compensatory mechanism by the HPG to try to increase testosterone production. However, testosterone production starts to decline in the mid-40s, and it decreases with time. So that can lead to decreased number of sperm cells, depressed mood, fatigue, and decreased strength in muscle and density. Similar to females, but it's less noticeable in general. Something that it can happen as well, and we talk about hyperplasia of the prostate gland, is enlargement of the prostate gland, which leads to compression of the prostate urethra, prostatic urethra, and that leads to urination problems. And they tend to go more to the restroom to pee as time increases or age increases in males. So that's all the part for the male reproductive system. Any questions before we move into the female reproductive system? Okay, so then for female reproductive system, we have internal structures like the ovaries, uterine tubes, uterus, and vagina. So that's what we call the internal female genitalia. And then external genitalia will be located in the vulva, which is the area between the labia majora. And then in here, we have, for instance, the vestibule of the vagina, and then we have the labia minora, we have the mons pubis. All of these are part of the external genitalia in females. Now, functions as a whole, it will be to basically for the uterus to allow the development of a conceptus or a fetus, and then to nourish an infant. So most of the female reproductive organs, they are located in the pelvic cavity, and there is a reason for this. So if you notice here, in the mid-sagittal section and in the superior view, when you remove these other structures that surround the reproductive system, the female reproductive system, it is located in the pelvic cavity, lower pelvic cavity, and it is posterior to the urinary bladder but anterior to the rectum. And then we have a folding of peritoneal membrane, which is called the rectal urine pouch, posteriorly, and then anteriorly we have the vesical urine pouch. And then this uterus, this is like a mid-sagittal section. It has this internal layer, which is called the endometrium, and then the middle layer, which is the myometrium, and then this visceral layer, external, which is the perimetrium. So the position of this uterus in the pelvic cavity, it is anteroverted like 45 degrees. So it's not falling completely into urinary bladder to prevent collapsing of this organ and then having incontinence. And it is not shown here, but we have some ligaments that runs between the posterior region of the uterus into the sacrum that are called the sacroiliac ligaments that maintain them in this position. But as you can see, this organ is protected by the rectum posteriorly and the urinary bladder anteriorly and the pelvic bones in here, which in this case will be the pubic bone. So if you see in the superior view, we have here the pubic bones protecting, together with the urinary bladder, the uterus. And then posteriorly, we have extending from the uterus these uterine tubes, and then here we have the ovaries. So, since in these organs we have the cells that produces the egg cells that are going to allow for reproduction, you will have one egg cell during reproductive age. You have one egg cell released per month. And then females, once they start puberty and they start ovulating, they start releasing one egg per month. Let's say that happens at age 15. And then let's say that ends in 50 years old, if so much. So how many years is between 15 and 50 years? 15, 1, 5, and 50. 35. So it's only 35 years that the female can reproduce. And out of this 35, it only once per month, 1 day of the month. So 12 days of a year she can reproduce. And now if she becomes pregnant, more or less, you subtract from those 35 years, 1 year, 1 year and a half. So let's say total 30 years, okay, of effective reproduction. We saw how many millions a male can ejaculate of sperm cells. And then they can reproduce basically any day of the week, even after andropause. Up to their old age, they still can reproduce. So then for us, females, it makes sense that we have these organs internally protected. I love males, I have 2 sons, but in terms of reproduction, we are most important. Okay? So then that is why we have these internal organs. And now we have this fat pad that we don't like it, but I remember one professor from dermatology, she told us, well, I mean, you don't like that because you like this kind of fashion where the females have to be super flat in their stomach and whatnot. But she said, but it is for protection of your uterus, this fat pad, the mons pubis. So yes, we have it there for a reason. So let's go into the details of each of these organs. So the ovaries, they have like the size of a walnut, says there. It's more like the size of an almond. So it is very light in weight, 6 to 8 grams, which will be kind of like a third of an ounce. And then these oocytes, they have a cortex, they have a medulla, and in their cortex, which is the external region, we have these cells that start the production of an egg cell, which is known as oogenesis. And then this area where we produce these oocytes is called the follicles. So the follicles will change as the menstrual cycle goes through, changes in size and also in shape. And then that happens under the influence of FSH and LH, but ultimately leads to the production of estrogens, which includes estradiol, estrone, and estriol. So these are the three versions of estrogens. And then progesterone. This hormone is important for the maintenance of pregnancy, and then inhibin and relaxin. The ovaries in the medulla houses blood vessels and lymphatic vessels and nerves. And they are supported by ligaments like the broad ligament that attaches the ovaries, uterine tubes, uterus, and connected to the bony pelvis. And then the ovarian ligament that connects the medial surface of the ovary to the uterus, to the lateral portion of the uterus. And then the suspensory ligament or infundibulopelvic that connects the lateral part of the ovary to the pelvic wall, in which you carry the branch of the aorta, the ovarian artery, and the ovarian vein. So the uterine tubes are long extensions that starts in the isthmus, that the nearest part to the uterus, and then they have a length of 10 centimeters or 3.9 inches. And internally, they have a lumen through which the egg cell passes en route to the uterus. Now, the next part of the fallopian tube or uterine horns, it has several names. So it is a widened portion that is called the ampulla. And then the ampulla connects to the infundibulum, which is like a funnel that receives the egg cell. And then the infundibulum has finger-like extensions that are called the fimbriae, that actually during the process of ovulation, the egg cell, basically, guys, there is no physical connection between the uterine tube, and the ovaries. There is actually a pelvic space there, or a space, physical space. So when the egg cell is released from the ovary, and if this was the infundibulum and the fimbriae, as the egg cell is being released, the fimbriae does this. It's like trying to catch the egg cell to prevent the egg cell from going into a pelvic cavity. So this happens in the middle of the menstrual cycle under the influence of luteinizing hormone or LH. The uterus is the organ that basically is held for the supporting of the new human being. And then this one implants the fertilized egg, which is known as, at that stage, blastocyst. And it provides nutritional support as well as physical support, developing what is called the conceptus. And then once it's fully developed, the conceptus has born. And then this organ has like an inverted pear shape, weighs between 30 to 40 grams. and then it becomes larger in female who has children. And it is held by different ligaments, like the lateral cervical ligaments, that they are the lower ligaments that holds the lower part of the uterus, which is known as cervix, and also the superior part of the vagina into the sides of the pelvic wall. And this is because you're not only trying to prevent, like if I'm, let's say that I'm the uterus, so if I'm like this, and this will be kind of like the urinary bladder, well, I don't go to one side or to the other. So these cardinal ligaments or lateral cervical ligaments also holds this uterus to not go to one side or the other. Uterosacral ligaments are the ones that I told you that prevent the uterus from completely falling into this urinary bladder. It can happen after several pregnancies in females. These ligaments, they become so stretched, they don't come back to their size. And then after 4 or 5 pregnancies, they have a lot of accidents. So they have to have a surgery in which they shorten these uterosacral ligaments, and then they move back the uterus to its normal position. And then the round ligaments connect the uterus to the anterior body wall. And then broad ligaments, which holds the majority of the body of the uterus, not only protects and attaches the uterus to the bony pelvis, but also the ovaries and the uterine tubes. Depending on which this area of the broad ligament is located is how you call it. If it's in the uterus, will be mesometrium. If it's in the uterine horns, will be mesosalpinx. And if it's in the ovaries, will be mesothelium. And then the regions. So the largest part will be the body, which is located between the lower part, which is the cervix, and the dome shape, the top part, which will be the fundus. And then the entrance to the uterus, which is happening through this cervical canal, it is called the external os. The wall of the uterus has 3 layers. Internal layer, endometrium. Endo, remember, means inside metrium. Anytime that you hear that, that refers something related to the uterus. And then that's very thin. It's endometrium is basically simple columnar epithelium. It has 2 layers. It has the functional layer, which is the one that it is discharged every menstrual cycle. And then it has like the stem cells that is the basal layer that regenerates the functional layer after menses. So that's the endometrium. The next layer, which is the thicker layer, is made of smooth muscle. This is the myometrium. This one contracts rhythmically during copulation, and it is under the influence, that contraction under the influence of oxytocin, and also contracts during childbirth because we have oxytocin receptors. And then perimetrium will be the outermost serous layer, which is made out of visceral peritoneum. Questions about the uterus? Okay, so vagina will be the organ of copulation in females. It is a virtual space. It receives the penis and semen during sexual intercourse, and it provides a passageway for the fetus and menstrual flow. The epithelium of the vagina varies in little girls, and in the elderly will be simple cuboidal epithelium. but during reproductive stage, it will change to stratified squamous epithelium without keratin. And then we have a lot of lactic acid producing bacteria that helps to decrease the pH of the vagina. And then the walls internally has foldings or rugae that expands during sexual intercourse. Now, the epithelial cells also has some cells that secretes glycogen, and then in most women, the mucosa that is near the distal orifice form an incomplete partition. It's called hymen, and on the sides of the entrance of the vagina, there are some glands that are called the Bartolini's glands that secretes a mucus secretion for lubrication for sexual intercourse. So here is the anterior view of the internal organs of the female reproductive system. Here is the closed view, and of course this is the open view. So, starting with the uterus. So this is the cervix. This is the cervical os in the cervical canal. And then this part is the body. This is the fundus. And then this is the uterine cavity. Walls, the layers. The internal layer is the endometrium. The thicker layer is the myometrium, and the external layer is the perimetrium. Here in the vagina, these transverse foldings will be the rugae, and then there is these fornix spaces that holds temporarily the sperm cells. And then for the fallopian tubes, this narrow portion is called the isthmus, and then this long portion will be the ampulla, and then here we have the infundibulum, and then this is the fimbriae, and then this is the ovary. Fertilization happens at the border between the ampulla and the infundibulum. And now for the cross section of the ovary. So this middle part is the medulla, where we have the blood vessels. And then this part where you have the follicles that are going to make the egg cell will be the cortex. And then it's hold the ovary into the lateral upper part of the uterus by this ovarian ligament that it also has blood vessel nerves that goes into the medulla. But also from the side, so this is medial, this is lateral, from this lateral side, you have this suspensory ligament that holds these ovaries into the lateral upper part of the pelvic cavity so that they don't fall. And then here you have the ovarian artery and ovarian vein. The ovarian artery is part of the gonadal arteries of the aorta. And then this round ligament holds the anterior part of the uterine tube, and then it's not shown in here, but we have on the posterior part the uterosacral ligaments. And then here is the broad ligament. So this broad ligament, when it's found in this region, it will be called the mesometrium. When it's found in here covering these uterine tubes, it's called the mesosalpinx. And when it's covering the ovary, it's going to be called the mesovari. And then here we have the lateral cervical or cardinal ligaments that holds this little part, the cervix, and the upper part of the vagina to the sides. Questions? Now for the vulva, which is the external genitalia in females. So this will be the structures that lie external to the vagina. The vagina is still considered an internal organ, of course. So we have this fat pad on the anterior part of the pubic bones, which is the mons pubis, that it is covered with hair after puberty. And then in between the thighs, in the perineal area, we have this thick folding of skin, which is the labia majora. Also, this one, after puberty, will get terminal hairs. And the skin is thicker than the most internal labia, which is this folding of skin, but this is the labia minora, and that skin is more sensitive, more thinner, and is not covered by hair. And then this labia minora encloses the entrace into the vaginal orifice, urethral orifice, and it is called the vestibule. Now, on the sides of the urethral orifice, which if you remember, the urethra in females is very small, very short, like about 4 centimeters in length. So we have a couple of glands that is called the paraurethral glands, or glands of skin. So this one discharges mucus into the urethra, and then at the entrance of the vaginal orifice, we have the greater vestibular glands, or glands of Bartolini, that secretes this mucus during sexual intercourse. Now, during development of the fetus, basically we have the structures in the pelvic area that are going to give rise to female and male reproductive organs, and we have analogs or equivalent of organs in females than males. So the equivalent of the erectile tissue in females that erects during sexual intercourse, just like as the penis in males. So the equivalent of the penis in females will be the clitoris. So just as the male, it has also corpora cavernosa, and it is basically engorged with blood, and it's innervated by a lot of sensory neurons. Now, the perineum, it will be the area that is located between the thighs, and is just as in males subdivided into the urogenital diaphragm and then the anal triangle posteriorly. Now, in females, we also have a type of perineum that is called clinical perineum, that it is the space between the posterior foldings of the entrance to the vaginal cavity and the middle of the perineum, the raphe, that can be cut during childbirth to prevent kind of tearing of these tissues within this organ, because maybe the head of the baby is too large. And forget about the head of the baby. I mean, the head of the baby is kind of this big when it borns. But the shoulder-to-shoulder ratio, it's wider. So as it's passing by, it can rupture these tissues. So then you make an incision that is called episiotomy, and then you just stitch it after childbirth. So here's the vulva in the perineal area. All this. So here's mons pubis. Internally, of course, we have the pubic bones, and then here are the foldings of skin. So here we have the labia majora, labia minora, and then this is the clitoris. Here is posterior to the clitoris, the urethral orifice. On the sides, we will have paraurethral glands, and this will be the vaginal vestibule. And here we will have these greater vestibular glands, or glands of Bartolini. And of course, this is the perineal. So anything here will be urogenital triangle, anything here will be anal triangle. Sometimes these glands obstruct, and then they enlarge, they become infected, can be unilateral or bilateral, and that leads to a lot of pain during sexual intercourse. And then, of course, as they become larger and larger, you have to perform a little incision there to drain it, to drain all the pus and the bacteria that is there. Any questions? I don't want to scare you. It happens, not so frequently, thankfully, but it can happen. Now, mammary glands. Mammary glands are not part of the reproductive system. And I told you when we talk about in AMP1 in the integumentary system that we will see better details of the mammary gland in this chapter. Well, the reason for this is because the mammary glands, although they are part of the integumentary system, the system of the skin and accessory organs and glands, is because this one helps to nourish the baby, these glands. So it's a modified sweat gland. And then it produces milk under the influence of prolactin hormone. And then we have between 15 to 20 lobes that basically have glands that they have these cells that produces the milk. And these lobes in between has these suspensory ligaments that attaches these glands into the pectoralis minor muscle. And then the ductules of these glands, they collect the milk and then they form a large duct that is going to empty into the nipple. And the nipple is surrounded by a wider area of darker skin that is called the areola. So, lobes have lobules. And then within these lobules, we have the glands or alveoli that will be the ones that produce the milk. And these alveoli are surrounded by myoepithelial cells that basically has receptor for oxytocin. It kind of go away as you lactate more and more, but it is very noticeable in a female who lactates for the first time that once the baby is sucking in the nipple, the female will feel the contraction of these alveoli, not the alveoli, the muscle, the myoepithelial cells, and it will feel a little bit of pain. But that eventually goes away with time. So then once the alveoli produces the milk, the myoepithelial cells contract, and the milk will go into the mammary ducts, and then into the lactiferous ducts, and then into the lactiferous sinuses that are near to this nipple, and then that will be released during ejection of the milk, either to suckling of the baby or maybe a device. When it comes to size of the breast, it's not depending on the number of lobes because we all have between 15 to 20 lobes, but it is dependent on the amount of fat tissue that you have. And independently of that, and of course that's a personal decision whether you want to lactate your child or not once you have it. Of course, it is advisable because you give an extra protection, you give IgA to your baby, and at the beginning, the first milk production, which is called colostrum, you give IgG too. But anyway, so independently of the size, the lactation process, don't think that it's going to be automatic. Some females, I don't know, they don't have a lot of sensitivity in the breast tissue to produce milk. They might not have enough receptors for prolactin, or maybe psychological, they don't release enough prolactin, so they don't stimulate the secretion of the milk. So it can be a large or smaller breast tissue, but lactation is independent of the size. And here is the mammary tissue. So this is And I said pectoralis minor before, but it's pectoralis major. So anyway, so this is like a mid-sagittal cut showing you internally. So this is the skin, of course, and then all of this is fat tissue, and then this will be the lobules within these lobes, and then these lobes are filled with acini, and in the acini we have these simple cuboidal cells that produces the milk, and the milk will go into these ductules, and then ultimately all the milk will end up in these lactiferous sinus that are just below the nipple, and this will be the areola. And then all of these connective tissue is called the suspensory ligaments, holds the breast tissue into the pectoralis major muscle. So then look at the difference between the size of the glands in a non-lactating breast and a lactating breast. So in a lactating breast, you have enlarged tissue. So this is basically this alveoli in a non-lactating breast tissue and a lactating breast tissue. Questions? So, clinical note, breast cancer is the second most common cancer here in US. Affects 2,000 females and males every year. So, breast cancer is not exclusive of females. It's also affecting males. Several factors play a role. Number one factor will be genetics. If you have family members from your maternal side, like an aunt, grandmother, your mom that has breast cancer, you better give yourself a chance and get an early test, because you can have inherited some genes like BRCA1 and BRCA2, breast cancer 1, breast cancer 2 genes. And then other factors will be obesity, because fat tissue also produces estrogens. And then estrogens are good, of course, because it maintains healthy tissue in our bodies like muscles, bone, etc. But also it's a growth factor. So that can lead to mitosis in your tissues in your body. So that can lead to breast cancer. And then the longer reproductive span. So by the way, well, we still haven't talked about the menstrual cycle, but the first menstrual cycle is called menarche in females. Okay, so early menarche and late menopause increases the chances for you to be exposed to estrogens, and then you have not only greater chances of having breast cancer, but also ovarian cancer. So that's one. And then no pregnancies or first pregnancy after the age of 35. Don't ask me the reason why for that, but yes, that is true. If you have a late pregnancy or you never been pregnant, there are other physiological factors by having pregnancies that counteracts the action of the estrogens. And then when it comes to detection of breast cancer, unfortunately, if you don't check regularly your breast tissue, like with self-examination, that of course you have to be trained for it, and then if you have family history of having breast cancer, and then you don't have these mammograms, chances are that you'll have a cancer that will be occult there in your body, and then most breast cancers are painless until they are advanced or have metastasized. So detection is the best way to prevent any disease, including cancer, of course. And then monthly examinations basically are targeted for detecting lumps that sometimes can be malignant. So here is some x-rays that can detect increased tissue density. Like this is normal breast tissue. This is the view of the breast tissue with some of these connective tissue. Some of these start like a tiny spicule of calcification that starts growing, and it's a tumor. So it says here that mammograms can detect small malignancies that are not palpable during self-examination. While that is true, it is also not true, to be true, guys, that yes, we still have differences in density in tissue in females. Some breast tissue is more denser than others. The denser the breast tissue that it is, the less likely that the normal mammogram detects the cancer. In this case, it's supposed to be done through an MRI instead of the regular mammogram, but not all the insurances pay for that. So it's sad, but I'm hoping that in the future there won't be, like, why not pay for more expensive tests? Because, I mean, what is more expensive than losing a human life? Okay, so tell that to insurers. Incredible. Anyway, so here is the summary of all of these structures that we saw. So we're not going to go over the detail. Let's move into oogenesis, which is the production of an egg cell. So the production of egg cells starts during fetal period. So we form the primordial follicles during fetal life, and then we start the gametogenesis or meiosis during that period, and we are rested in prophase 1. And then once we're born, we reactivate during puberty this gametogenesis. And that will end at menopause, which is usually for females, between 45 to 55 years old for females. There's no menopause in males. Anyway, so what happens before birth is that we have this oogonia that undergo mitotic divisions during the first 2 to 7 months of fetal life in females. And then by month 7, we have around 7 million oogonia. But then we're born, and then we have less oogonia. Now, between 1 to 2 million will undergo meiosis 1, and we arrest in prophase 1 these primordial follicles, and then after we resume this, we will have the development of primary oocytes. So then out of 1 of 2 million of these primordial follicles, we will have around 300,000 that they can be potentially making these egg cells. So then once you have the starting of puberty, you will release GnRH by your hypothalamus, and then you will stimulate with FSH the growth of these primordial follicles into primary follicles and then into secondary follicles, which will hold the primary oocyte, the secondary oocytes, and then the secondary oocyte will arrest again in meiosis, but in this case it's going to be meiosis 2 in metaphase. So in metaphase, you will align the 23 chromosomes there in the metaphase plate, waiting for the 23 chromosomes of the sperm cells to complete meiosis. If fertilization doesn't occur, no meiosis resumes. So then each month, around 20 to 30 primary oocytes continue to develop. And only one it is ovulated out of those 20 to 30. And then during gametogenesis, you will produce a mature oocyte that is going to be accompanied by polar bodies. So polar bodies will be cells that they have a nucleus with chromosomes but very little cytoplasm. And the one that keeps most of the cytoplasm will be what is going to be the secondary oocyte. And that cytoplasm is very important because it's going to carry genetic information for the baby. And it's going to have the organelles, including mitochondria. Now, centrioles come from the dad side. Mitochondria comes from the oocyte, from the female side. And then again, we have a lot of genetic factors that are going to give instructions for the development of the baby. So the secondary oocyte, then, it will be the one that begins meiosis 2. And then once it completed, it will form the ovum and a second polar body. And if not, it's going to disintegrate. And then of the 300,000 primary oocytes, only about 400 to 500 become mature during the reproductive life. What is 12 times 30? 360 more or less? 360. So basically, that can be the many chances that we have to reproduce if, of course, we don't get pregnant. So here are the stages of oogenesis: before birth, childhood to puberty, and puberty to menopause. So the oogonia, which is a diploid cell, undergo mitosis, create an oogonia and a primary oocyte. This one will be arrested in meiosis 1, prophase 1. We born, during childhood nothing happens, and then gametogenesis continues after puberty. So this primary oocyte become a secondary oocyte, and you shed a first polar body. And then this one will become arrested in metaphase 2, and then it will continue to form an ovum if continue the process of meiosis if it's fertilized by a sperm cell. So then the sperm cell will complete again the 2N. So here we have 2N, 2N, 2N. So basically these are diploid cells. Then this will be a haploid cell, the secondary oocyte in metaphase 2. And then you form a zygote from the fertilization of an ovum. So remember that during this process of meiosis, we have separation of the sister chromatids from these diploid cells, so that you can end up with only an egg cell that has 23 chromosomes, a member of each pair. But then, think about it this way. From this period of time where we form our first cells, our primordial cells, up to when we mature them, like let's say 30, 40 years old, the mitotic spindle becomes less effective. And then sometimes instead of separating some chromosomes, the chromosomes are dragged into one cell as a pair. And then it's fertilized by a sperm cell that has regular number of chromosomes. So then what will happen? A trisomy of any kind. So the most common trisomy that we have is Down syndrome. And this happens because sometimes these 21 chromosomes, they don't separate. This is called non-disjunction. And this is like the one that survives the most, but there are some other ones that either don't make it an early life on stage, or they may be aborted or miscarriage, because these trisomies are non-viable. So trisomies can come because an egg cell has an extra chromosome, but also because of sperm cell, but it's most likely that it comes from the female side, because it takes for us more to produce a gamete than in males. Males, they produce the gametes really quickly. So it's more efficient, the process. So concept boost, spermatogenesis versus oogenesis. So you have both producing haploid cells with unique combinations of alleles, but there are functional differences. The sperm cells are produced in large numbers, and in females, only one per month. And then the sperm cells, they produce enzymes to penetrate the oocyte. The female doesn't produce those enzymes. The egg cell, they don't produce it. And oocyte production begins at birth, before birth in females, and in males, it is produced after birth in puberty. And then because of that, for us, there is no much, reason for why we have to produce multiple secondary oocytes at one time. And then sperm cells are much smaller than oocytes. Actually, oocytes can be seen without the aid of a microscope. And then secondary oocytes receive additional cytoplasm, because, again, the cytoplasm, it is necessary to give instructions for development of the fetus. So that's the table with the differences. And then here's the actual process of maturation of an egg cell. So you have your primordial follicles that will form primary follicles and then secondary. Everything under the influence of FSH, follicle stimulating hormone. And then once you have a mature oocyte, you release it with LH, luteinizing hormone. And then since you stimulate between 20 to 30 oocytes, and only one it is released, the rest undergo atresia, which is death. And then the ovarian cycle, it is under the influence of several hormones that are part of the hypothalamic pituitary gonadotrophic axis. Now, the ovarian cycle has 4 stages then. Primordial follicle, where your oocyte is surrounded by a single layer of squamous cells. And then the primordial follicle, where your cells, instead of being squamous, become cuboidal, and these cells are going to be called granulosa cells. And then your oocyte has grown in size, and then you will have the creation of a membrane that is called the zona pellucida, which is the one that will hold receptors for the sperm cells, so that the sperm cells will bind into the egg cell. And then the secondary follicle, your granulosa cells will be secreting a fluid that is called follicular fluid that is going to accumulate between the oocyte and these cells, and the oocyte, and then you will have the stimulation of the nearby cells to form a layer of cells that are called the thecal cells that are going to be the ones that produces the estrogens. So it is in the secondary follicles then when you start producing these estrogens, and then in the last phase, which is the vesicular phase or tertiary follicle, under the influence of high levels of FSH and LH, you will accumulate more fluid that is going to push so much this primary oocyte into one side, and then you will have some cells that are called cumulus cells that project into that space where you have the fluid that is called the antrum. And that all these structure is called the Graafian follicle or bone graft follicle. And it's very distinctive, it's very nice how you see them in the microscope. So some of these tertiary follicles can reach up to 1 centimeter in diameter. And imagine having a bunch of them there. So that's why we have these cramps. It's not imaginary, okay? It's a lot of this tension in the cortex of these ovaries. And then unless fertilization occurs, it takes between 90 to 120 days to mature completely a vesicular follicle. And then the last stage is ovulation, in which the secondary oocyte is released, goes through the space like leaping, trying to be catched by the fimbriae in the fallopian tubes. And then the empty space is going to be the one that is going to form the corpus luteum, that is going to secrete progesterone, in the hopes that there is a pregnancy, and then you maintain a thick endometrium so that the baby will receive nutrients and will be nourished. So here are the different phases. You're magnifying this region of the ovaries, which is the cortex. So you have your primordial follicle with your primary oocyte in the middle, and these simple squamous cells, which are the follicular cells. So it's this. And then you mature this, so it becomes a little bit larger. So now it's going to be called the primary follicle. So these follicular cells will form more layers that now are going to be called the granulosa cells. And then the external cells, so these are the granulosa cells. The external cells are going to be the thecal cells, the ones that produces the estrogens. And then the secondary follicle is where you start producing these pockets of follicular fluid. And then ultimately you will form this antrum, which is when all of these pockets merge. And then you will have accumulation of these estrogens in this region, and your secondary oocyte will be pushed to one side. Your primary oocyte will be pushed to one side, and then it will be ovulated, which is when the follicle ruptures, then the wall, the wall of the ovaries open, and then you have the luteal phase, in which you produce progesterone out of the corpus luteum. Now, if the female does not get pregnant, this corpus luteum regresses, and it will be called the corpus albicans. And then because you have decreasing progesterone levels, you start a menstrual cycle. So it takes around 10 days for this corpus luteum to degenerate, and then you form your corpus albicans. So here is the rest of the phases of the ovarian cycle. So you have here ovulation by rupture of this wall. So look in this nice microscopy. And then after that, you form this corpus luteum and then corpus albicans, which is the remnant of the corpus luteum. So if you assume that the menstrual cycle lasts 28 days, you can tell that around day 14 is when you expect to have ovulation. The first phase of the menstrual cycle is called menses, of course, day 0 to 4 or 5, depending on how long it lasts, this shedding of blood. But then you have this proliferative phase in which after you shed this endometrium, the endometrium regains again its thickness, and then you have ovulation, and then the last period, the next 14 days, assuming that there is not going to be any pregnancy, is going to be the secretory phase. In the secretory phase, the endometrium secretes fluid-reaching glycogen. Just in case that you had pregnancy, the baby will be attracted into this area by these nutrients, and then it will be implanted. And then the period can be as short as 21 days up to 40. And then you can have between 1 to 2 days fluctuations. So that's all for this chapter. Do you have any